This audiocast will deal with two areas of problems that one faces with contraception, and that is the patient who presents with headache as well as the obese patient. So then when you look at a headache, I think it's important to keep in mind there are a number of topics that are important. Given the frequency, particularly of migraine headache, we will spend most of our time talking about migraineurs and the issues that one has in coming up with contraceptive methods for them. So what we will basically focus on is, can women with migraine headaches use combination hormonal methods? How does one manage women with migraines during the hormone-free interval? And can women with severe headaches that are non-migrainous use combination hormonal methods? Obviously, use of LARC methods are appropriate for these individuals, but it's really the questions arise whether products containing estrogen are appropriate or even progestin-only products. If you look at migraine headache in the United States, this is an important topic since migraine affects about 43% of women in this country. And the data does suggest that all migraineurs have some increased risk of stroke. So that if you add another risk factor, such as combination hormonal products, obviously this would be of some public health interest. Migraine without aura is the most common subset among the migraineurs, but migraine with aura tends to be more problematic relative to its increased risk for stroke. Now, when we talk about aura, at least 95% of auras are visual. Flickering lights, spots, zigzag lines, or you may have pins and needles, or even dysphasic speech. Aura precedes the headache and usually resolve within 1 hour after the headache. Risk factors for stroke include age, combination oral contraceptives, smoking, and hypertension. If you look at the overall risk of ischemic stroke among individuals with migraine headache, you can see that in a meta-analysis of 14 observational studies, the risk of ischemic stroke among all migraineurs was about twofold. Among migraineurs without aura, it was about a little less than that, but increased with those with aura to about 2.3 relative risk. Now, even though we're looking at roughly doubling of relative risk and then perhaps slightly higher for those with migraine headaches with aura, keep in mind that the absolute risk of ischemic stroke among reproductive age women is quite low, again in the range of 10 or 11 per 100,000 women years or less. However, this is an important topic because if stroke develops, it has serious consequences in terms of recovery, and again has a reasonably high case fatality rate. So what about the risk of headache and the risk of stroke with a variety of risk factors? So here are two case control studies where they looked at various risk factors, published again a number of years ago. Migraine by itself does increase your risk of stroke. If you are a smoker, additional risk is shown in the first study by Sorrell. You can see that it increased to almost threefold versus women who were just migraineurs without smoking. And keep in mind the addition of oral contraceptives again has at least an increase similar to that achieved by smokers, or even higher, at least in one of the two studies shown here. But what if you were a smoker, user of combination oral contraceptives, and also a migraineur? You can see there's a dramatic increase, at least based on the data in the CHANGE study. So, how do you prevent estrogen withdrawal menstrual migraines? And this is a topic that's important because a number of women will have migraines that occur primarily in the period of time when they're not taking the combination hormonal product. And you can do this by reducing the hormone-free interval with the use of combination oral contraceptives to maybe 3 or 4 days from 7 days. Or you may go to the continuous use, that is roughly 3 months, and then have a withdrawal period, and then use them continuously for 3 months. And certainly data suggests that this works reasonably well. Or you can consider using non-steroidal steroidal anti-inflammatory agents starting 7 days before the onset of menses and continuing for a couple of weeks afterwards. And there is at least one clinical trial that did show that it did reduce the frequency of migraine attacks, the duration, and the severity. What about the overall risk and benefits of using combination products? How does this stack up, particularly in an organization such as the USMEC data from the CDC? In general, they feel in their review of the data that the benefits outweigh the risks with non-migrainous headache unless it's persistent after 3 months of combination oral contraceptive use. So again, we're looking here at all headaches. If they're not migrainous in nature, in general, it is okay unless these headaches persist after the product is started. With migraine without aura, the benefits usually outweigh the risk, starting women who are less than age 35. However, the risks tend to outweigh the benefits if women are age 35 or older when they start, or who develop migraine headache while on the combination oral contraceptives, or who have other risk factors for stroke. Finally, combination oral contraceptives are felt to be contraindicated in women who have migraine with aura. So to answer our three questions, can women with migraine headaches begin use of combination hormonal methods? Yes, if no aura and not over the age of 35. Can women with severe headaches that are non-migrainous use combination hormonal methods? Possibly, but one needs to discontinue if the severity persists or worsens. And how does one manage women with migraines during the hormone-free interval? And again, you would consider the continuous method or shorten the hormone-free interval. So going to our next topic, and that is obesity and contraception. This certainly is an important topic. Since 1980, the frequency of obesity of women in the reproductive age group has doubled, such that about 1/3 of women in the reproductive age group are now obese. Now, it's clear that IUDs are effective in women who are obese, essentially since they work locally. However, the use of hormonal contraceptives that require systemic distribution raises the theoretical risk of decreased efficacy in standard doses. Also, since obese women face a number of health risks, including venous thromboembolism, there is concern whether the additional risk with estrogen-containing contraceptives raises concern for safe use in this population. Finally, how does bariatric surgery affect efficacy of hormonal contraceptives in women who have undergone these procedures? So here is a Cochrane review of hormonal contraception in overweight or obese women. And in this, there were 11 trials involving about 38,000 plus women. One study using BMI found higher pregnancy rates with lower dose pills in overweight and obese women. With the patch, the efficacy studies that were reported when the patch was brought to market did show that a higher body weight, but not BMI, was associated with some increase in pregnancy rate, but here again the numbers were fairly small. Vaginal ring studies did show that there was a higher pregnancy rate when weight exceeds 70 kilograms. Again, this is a fairly a modest weight differential. However, 2 implant studies showed no trend in terms of change in efficacy by body weight. But again, we need to keep in mind that most randomized trials that look at contraceptive efficacy in terms of bringing new products to market exclude obese women. So we do not have a good handle on efficacy rates in these individuals. Further, observational studies, with their increased risk of bias, contribute most of the data in this area, and albeit even though they contribute the data, the number of studies are limited. Overall, the CDC and their MEC criteria suggest that benefits outweigh risk for the use of oral contraceptives, the patch, or the ring, and there are no restrictions otherwise for other forms. So they don't give the, shall we say, the dark green color coding, but they do give the light green color coding for combination agents. What about obesity and venous thromboembolic risk? Certainly by being obese, that risk is increased, And here the data also is a little bit muddy. There's a Dutch case control that did find that oral contraceptive users with a BMI greater than 25 compared to those with a BMI equal to or lower than had actually a 10-fold increased risk of venous thromboembolism. A British case control study also found an increased venous thromboembolic risk with a BMI greater than 25, and if greater than 35, the risk was 3 times higher than that of normal weight users. So again, 2 studies done overseas that show there is some increased risk of venous thromboembolism. The CDC in their MEC guidelines has no restrictions to any form of contraception among obese women, particularly looking at venous thromboembolic risk. However, ACOG in its publication suggests more consideration should be given to using progestin-only forms of birth control and IUDs in overweight women because of the concern for venous thromboembolism. What about bariatric surgery? How does that affect potential for contraceptive efficacy? Here again, the issue has not been adequately studied. One study demonstrated 2 out of 9 oral contraceptive users became pregnant after a biliopancreatic diversion. Another study of 7 morbidly obese women after jejunal ileal bypass had decreased levels of oral contraceptive steroids compared to controls, suggesting that in fact perhaps there were inadequate levels of contraceptive hormones to be efficacious. Clearly, when you look at malabsorptive procedures such as the Roux-en-Y bypass procedure, they do decrease absorption, whereas restrictive procedures like banding do not. So although the data is limited, the CDC recommends against using oral hormonal contraceptives in the presence of malabsorptive procedures, but not restrictive procedures. They list no restrictions relative to the use of the vaginal ring, the patch, the injectable implant, or levonorgestrel releasing IUD, since again, these bypass certainly absorption within the GI tract, and then therefore would not be effective. So to summarize, does obesity affect the effectiveness of hormonal contraceptives? Possibly, but here again the data is limited as we just discussed. Are the risks higher for obese women who use oral contraceptives? And there appears to be some increased venous thromboembolic risk, and I think it certainly would be supported in other literature that is non-contraceptive in nature, such that certainly one should consider, if possible, progestin-only methods or the copper IUD. Does bariatric surgery affect efficacy of oral contraceptives? Possibly with malabsorptive procedures, but here again, the data is limited.